Cell Lines by Dr. Anita Burgess. Now let's start the session.
I welcome you all to this session now, and I would like to give a disclaimer that these are little tougher cases that we have chosen today, so that we are giving an example how flow and molecular are helping us in diagnosis. So please feel free to ask any questions you have, so and enjoy the session. So we'll begin with case one. I request Ankit to please read the history.
Yes. So 17-year female, fatigability for 4 months, fever for 10 days, decreased appetite for 10 days. Upon CBC examination, hemoglobin 4.9 gram per dl, platelet 32 in 32, total count 3.5 in 10 to power 9, and pro, please promyelocytes, right? Uh, P32.
Increase.
P stands for promyelocytes. What do you think,
P
Ankit?
stands for polymorphs. In a
Oh,
differential count, yeah. In a differential
okay,
count
okay.
in pixel blood, yeah, yeah.
So neutrophil 32%, lymphocytes 45%, monocytes 22%, and eosinophil 1%. And she has received blood transfusion of 4 units PRBC and 4 units RDP.
And the absolute monocyte count is 770 per microliter in this case. Okay. So we have a young female with an acute episode history and bicytopenia. And in percentage wise, there is monocytosis. However, absolute monocyte count is not raised. That is 770 per microliter, right? So what do you think in the bone marrow aspect? How is the cellularity? Okay. Lena, what is your finding in this slide?
Ma'am, it is hypercellular, and I can see megakaryocytes in this slide.
Right.
Shown.
And if we look at megakaryocyte, do we think it is normal or abnormal?
Abnormal.
Ma'am, I think it is abnormal because there is fragmentation of the nucleus.
Fragmentation of nucleus. So, what term do we use for this thing?
This for
What are features of this megakaryopoiesis?
fragmented nucleus, and if the
Do we use the term
hyperlocated or
fragmented?
hypolocated
Anyone else? Aishwarya,
abnormal.
Pardon, ma'am?
what term do we use for nucleus like this? This megakaryopoiesis features. Jhansi, do you want to attempt on it?
Yes, ma'am. It is a dysmegakaryocyte. It has megakaryocytes with separated nuclei, ma'am.
Very good.
With lobes completely separated.
Very good, very good. So among the feature of this megakaryopoiesis, we have hypolobation of megakaryocytes, micromegakaryocytes, and multinucleation, you can say, or you can say separated nuclei. The nuclear lobe are separated from each other. So that is what we use term. We cannot use other terms like fragmentation is not a correct term to be used, though you may mean the same thing, right? Now, what is the finding that we see in this slide? What's
Ma'am, here we can saw that some blasts
very
are
good,
there,
very good. Blast are
and some
increased. Yeah.
and on
Okay. So, and what about this kind of cells? How do you define this? Cleaving of nuclei and loop this convolution in the nuclei. How would you like to define this cell?
lobated nuclei.
Yeah. So, promonocytes kind of appearance they are
Yeah.
giving. So, blast and promonocytes are there. Okay. Now, if we look at granulocytic series, do we see anything like Ayushi, would you like to comment on this neutrophil?
This is showing a dysgranulopoietic feature in the
Okay.
neutrophil. The
Okay.
nucleus is. Yes, ma'am.
Yes, yes. So go ahead, what you were saying.
The nucleus is not multilobated as it is seen in the normal neutrophils.
Rather, granularity is weird in this neutrophil.
Granular neutrophil.
Granular neutrophil is there. What is this cell that we see here? Jhansi? Can you see my pointer? I'll just change it to laser. 1 second. This cell that you see.
Neutrophil, ma'am.
Okay. Anyone else has difference of
Eosinophil.
opinion? Yeah.
Eosinophil, ma'am.
Yes, yes. So Ruini correctly said that this is eosinophil precursor. I request, please do not request to annotate. 1 second. So what are the features of dysgranulopoiesis we have? We have nuclear features, we have cytoplasmic feature. Among the features, we had hypogranularity in our case. Okay. The erythroid precursor were normal in our current case. So if we wish to summarize the findings in bone marrow aspirate, what all we saw? Ruvini, would you like to summarize the findings?
Yes, ma'am. There were the increased blasts with including monocytes,
Right.
and
So
there
I
were
like to emphasize while counting, we counted in multiple areas, but the blasts were not crossing 20%. They were in range of 15 to 18% maximum. They were not crossing 20%. But anyway, increased blast up to 18% we had. Then
and there was this megakaryopoiesis
correct,
and this granulopoiesis were there,
correct, right.
along with the increased blast percentage of 18%.
Perfect, perfect. So in peripheral blood, we had seen monocytes, which were 22%, right? And apart from that, these were the bone marrow findings that you have correctly summarized. Now, based on bone marrow morphology, what is your diagnosis at current stage and what would you like to do next, Ruvini?
Yes, ma'am. The morphological diagnosis would be chronic myelomonocytic leukemia type 2, and to further diagnose, I would like to go ahead with the flow cytometry as well as molecular studies.
Okay. One more thing that in we should go for cytochemistry to look at the lineage of these blasts. I have not shown the slide, but these blasts were weakly MPO positive. Now,
And
Ankit,
the
could you?
special strains also, ma'am.
Yes, special strain. So, and NSC also, non-specific esterase, were also was also positive in these blasts. Okay, so now if we go to this, Ankit, would you like to tell what are these blue cells here?
And these blue cells, they are lymphocytes
And why do you say so?
because the lymphocytes, they have got the least granularity and
Mhm.
they are much more means
Okay.
they are much more
So
larger in size.
quantified bright and low side scatter, that means lower granularity as well as lower size, right? So main it is lower side scatter means complexity is less, so granularity is less, so that is why we are getting 45 bright cells lymphocytes here. So what are these
Did you
purple
say
cells,
lymphocytes were
Lena?
larger, Ankit? Did you say that?
That is what I also.
Ankit, did you say
It's
lymphocyte are the larger cell in among these cells?
no, sorry, I think that's wrong.
Yes.
Yeah, I said
Sure.
that, but
Yeah.
Sure.
So
Sure.
I
Okay.
think 45 bright you meant, but these are, yeah. So Lena, what are these cells in purple?
Ma'am, these are monocytes. because the site scatter is more as compared to the previous one, the lymphocytes, and more. I think that's it.
And 45, how is the 45?
Ma'am, it is more.
Is it
CD 40,
equal to lymphocyte, more than lymphocyte, lesser than
ma'am, it is
lymphocytes?
equal to lymphocytes.
Yeah, so as bright as lymphocyte 45, but higher side scatter. And what are these green cells, Aishwarya?
Ma'am, these are granulocytes. Ma'am, because these have the highest granulations, and ma'am, they are moderate on CD45.
Yeah, so but as compared to monocyte and lymphocyte,
They are
the
lower.
45 is dimmer. Yeah,
Yes.
yeah. And here, what do we have, Jhansi, in this area?
Blast,
Progenitor area. So we have,
progenitor,
yeah.
blast population, immature cells.
Okay. Now we will look at the myeloid blast in this case versus a normal case. So first, let me explain in this 34 versus 38 plot. We see this red is normal myeloid blast. This blue portion is a normal stem cell compartment. So how they are? They are 34 brighter and 38 dimmer cells. Okay, so lower panel is for normal, upper panel is for our current case. So let us compare and see if these current case blasts are normal or abnormal. So now, would you like to say, do you see any difference between 38 versus 34 in the upper versus lower, that is compared to normal?
No, it's different one.
It is different. So what difference are we seeing?
34, the intensity of 34 is less,
Yes, correct. And in
and
38, we are seeing clustering.
yes,
Okay, so we are not seeing a population that is 38 dimmer here. So they are supposed to be in this plotted area, but however, we can see a clustering with 34 dimmer and 38 showing clustering. Okay, Ayushi, here in 117 versus DR, compared to normal pattern, do you see any difference here?
Ma'am, CD117 is quite scattered. It is showing slight dim positivity. And this HLA-DR as compared to the normal, it is more towards coming towards negative side. It is dim positive.
Right, correct. Okay. So again, in 34 versus DR also, the stem cell again, they come like this. 34 brighter cells have a lower DR expression in the stem cell compartment. But in this case, how are we seeing it? One second, I'll just move this. You can move the video portion in your screen too. Ankit, would you like to say how do you see in this plot? What is the difference from compared to normal here?
Ma'am, CD34 expression is very much scattered, just like the previous one, but
34 is
HLA-DR,
dimmer, right?
is taking a more negative side. That is, it is becoming less and less.
Right. So now if we see another plot here, Ruvini, would you like to comment on this? On the left side is our current case, right side is a normal 7 versus 13 plot for myeloid blast.
CD7 expression seems to be higher than in the normal population, ma'am. And CD13 too seems to be more expressed on the current case than the variable expression seen on the normal.
Right. So in CD13, like the blast are predominantly CD13 positive, and CD7 expression is being seen in 13 positive blast also. So what if when in the normal myeloid blast, 7 may be expressed. It is not abnormal, but they are expressed in the 13 negative portion. However, in this, we can see that there is deviation from normal pattern that even in the 13 positive cluster, we are seeing CD7 expression. Okay. Now, We have seen this last plot already, but now we had already seen the CD34 expression in other plots, which was going towards dimmer side, but 13 actually is variable like in normal also. And here also 117 also is not showing significant difference as compared to normal blast. So now if we try to see, are these blasts normal or abnormal? Ruvini, would you like to say in our case, are these blasts normal or abnormal, myeloid blasts?
Abnormal, ma'am.
Okay. Now, these are abnormal myeloid blasts, but one thing was that in morphology, we had seen 18% blast plus promonocytes, whereas in this, I would like to inform that the blasts were just 0.6% abnormal myeloid blasts. Why would this be happening? Any reasons you could think of? Anyone else would like to attempt this question? Okay, so what happens is during when you're doing bone marrow aspirate, you may dilute the aspirate sometimes. So that may be one of the reasons. But in this case, we had also seen promonocytes, and those are usually CD34 negative. So that is why the 34 positive component that we have seen is very low in this case. So just based on CD34 positive component, you should not comment on percentage of blast on flow. So you have to take into account morphology for quantifying the exact percentage of blast. Okay. So now we have seen that these blasts are abnormal, and we have seen what were the abnormalities. Now next we will go to the granulocytes. Ruvini, left side is our current case and right side is a normal pattern. Do you see any abnormality in the granulocytes here in our case?
Yes, ma'am. Yeah. The CD13 expression seems to be much dimmer rather than in the normal population. And there's a cluster of CD16 bright positivity with regard to the in comparison with the normal population, which are CD13 and CD16 bright positive.
Right. So if you see in 13 versus 16 plot, there is a pattern of maturation in normal. This is also called Nike pattern. Okay. So what happens is as the cells, they mature from promyelocyte stage, they lose the CD13, go to the myelocyte stage. In the metamyelocyte stage, they gain CD16, and in the mature neutrophil, they are both positive 13 versus 16. So in a normal bone marrow, you should be getting a continuum of this pattern, that is Nike pattern, like seen on the right side. While in the left side, what we are seeing is abnormal clustering of these cell, and we are seeing a loss of this Nike pattern. Okay. Now, if we go to the next slide, we have 13 versus 11B. So, anyone, Ankit, would you like to compare the normal versus our current case now, 13 versus 11B?
Yes, ma'am. We can, in the normal scenario, we can see a transition that is taking from CD13. First, it is decreasing, and then CD11 is coming up and it's increasing. But in the current scenario, we don't see this smooth transition. Uh, Rather, we can see more clustering towards the
Shweta, your battery is on very low power. I think your battery is very low power, Shweta. Just check.
I'll just check, sir.
It might, you just might die anytime.
1 second, sir. I'll just plug in.
Yeah, okay, Ankit, you can go on. So you are comparing 1311B, no?
Yes, and we can see abnormal clustering here. The smooth transition is not present.
Similarly, in 11B16 also, like you were saying, there is some abnormal clustering, right?
Yes.
In this case. Yeah. Yeah, Shweta, I think is back.
Yeah. So yes, in 13 versus 11B pattern, we are supposed to see this U pattern that is there. which is missing. Again, 13 down regulation is there, and clustering is happening in 11B versus 13 plot. While in 11B versus 16 and 13 versus 15, the maturation pattern is almost maintained. We can see inverted 7 kind of pattern, both in our case as well as normal. And 15 is present in all granulocytic cells. So basically, it is the pattern is maintained in 13 versus 15. So are these granulocyte normal or abnormal? Ayushi?
Shweta, is it charging? Because it still shows red color. Yeah, now it is charging. Again, it is not charging.
Okay.
Maybe,
I'd
I'm not sure.
actually
Is it
one.
charging? Does it show on your laptop?
Yes, it
It's
shows
charging.
now that it
Now
is
it is
charged.
charging. Okay.
Okay.
Ma'am, it is
So
showing a bit abnormality in cases of with respect to CD11G.
okay, so now we have disc granulopoiesis, and in disc granulopoiesis, we have loss of pattern of 13 versus 16 versus 11B. Okay, so now if you go to the monocytes, Ruvini, would you like to comment on the current case? Why are we seeing two clusters in the monocytes here? Ruvini, are you there? Okay, so Ayushi?
Yes, ma'am. As compared to the normal, ma'am, the clustering is shown. It is not showing a homogeneous population.
Okay.
In our current case, it is showing clustering at some places for HLA-DR as well as for CD14.
Okay. So what would this population be which are HLA-DR bright while 14 negative? Would they be mature monocyte or immature monocytes?
They will be immature, ma'am.
Correct, correct. So in normal maturation pattern, what happens is HLA-DR is HLA-DR is positive, but it gets dimmer as it matures, and at the end, both 14 and HLA-DR are bright. So you can see a Z kind of pattern that is there for monocytic maturation series. But we can see that here we have two clusters of immature and mature monocytes in this case. Okay. Now, here I had given this plot of comparing classical versus non-classical monocyte, but I have used 45 versus 16. Would anyone like to attempt that? What are the markers that we try to look for classical and non-classical monocytes? Jhansi,
CD16 is an NK cell marker, ma'am.
right?
Mm.
Do we use any other marker to see classical versus non-classical monocyte?
64.
Okay, that is a monocyte marker. Okay, for now, I'll explain that in our current case, we have classical monocyte in the bone marrow, 95.9%. I'll explain it further. So we have in monocytes two things: immature fraction is increased with clustering and increase in classical monocytes, right? So now if we look at the diagnostic criteria for CMML. These were the previous criteria that are there. Prerequisite criteria are supposed to be met. Only thing is that now relative monocytosis is also there, which says if the peripheral blood monocytes is more than 10%, that also can meet for the criteria for CMML. Now, in the supporting criteria, we have one criteria where we are talking about abnormal partitioning of peripheral blood monocyte subsets. What do we understand by that? So, the monocyte, when we talk about classical versus non-classical monocytes, we categorize it based on CD14 versus 16. The classical monocytes are CD14 positive while 16 negative. Intermediate are 14 and 16 positive. while non-classical are 16 positive, 14 negative. So in cases of CMML, the classical monocyte fraction increases significantly. And if you have a cutoff of more than 94%, it points towards diagnosis of CMML. So this abnormal fraction part has been included in current WHO diagnostic criteria also. Okay, so this becomes important by using flow cytometry. So now, till now, in morphology, we had talked that our diagnosis was CMML. Okay. So now, after immunophenotyping, what is our diagnosis, Ankit?
So after immunophenotyping, it is CD. Hmm.
What is our diagnosis? Lena?
It's still CMML.
Till CMML, correct. So what would you like to do next?
Uh, Genetic.
Genetic testing. So we did NPM1 mutation testing. So how did we test? We used a fluorescent label primer. So we are doing a multiplex PCR. We're using primers for both NPM1 and FLT3 ITD, FLT3 internal tandem duplication. So what happens is our forward primer is fluorescent labeled. For a normal scenario where NPM1 is wild type, it is supposed to give us 170 base pair fraction or fragment. While if there is four base pair insertion or any base pair insertion for that matter, among which the most common insertion that NPM1 in that happens in NPM1 is four base pair insertion, and you will get a fragment of 174 base pair in addition to 170 base pair. Okay, so if we look at the capillary electrophoresis image, would someone like to interpret this, Ayushi?
Yes, ma'am. Ma'am, here the black peaks are for NPM1 and for the blue peak is for FLT3 wild type. There, the black peaks, they are showing two peaks suggestive of one mutation is also seen. While in FLT3 only one peak is shown, that means mutation is not there.
Right.
So here the mutation is only in NPM1 and not in FLT3.
Okay, so in fragment length analysis, we are seeing two peaks here, which is indicating a four base pair insertion. We can see two peaks at one is 170 base pair, another one is 174 base pair for NPM1, while for FLT3, we are seeing only one peak, that is wild type peak. So as correctly pointed out, this is an NPM1 mutated case. Now, what is our final hematopathology diagnosis, Aishwarya?
This is a case of well, with NPM1 mutation.
NPM1 mutation, but in a CMML, can a CMML case have NPM1 mutation? No, it can never have. Jhansi,
NPM mutation is usually seen in AML, ma'am.
usually seen. Can it be seen in CMML also?
Yes, ma'am.
It can be seen. What's any difference of opinion?
AML have seen NPM1 mutation.
In AML, NPM1 mutation is seen. Okay. So now, this is actually case of AML with NPM1 mutation, because now with presence of NPM1 mutation in the new WHO, you don't need you have to call it AML only. So even if the blast count does not cross 20%. So apart from NPM1 mutated AML, or AML with NPM1 mutation, any other case you know of where a cutoff of 20% is not required for diagnosis of AML? What's
Translocation 821.
correct?
That translocation 821.
Correct. Anything else?
Then inversion 62.
Correct. Anything else?
and 1517, translocation 1517.
Correct. Anything else? Anyone else? Any difference of opinion?
Ma'am,
Ma'am,
RUNX1
according to the new,
mutation.
Anyone else?
go to the new WHO classification for all the translocations, recurrent genetic abnormalities, no need of a blast cutoff of 20%.
So all, is it all or any specific? Like any
Other than,
specific
other,
entities are excluded.
yeah, uh,
So, okay. So, apart from AML with BCR-ABL1 fusion and AML with SEPA mutation, all other entity do not require a cutoff of 20% for diagnosis of AML. If you are having any of these fusion or these defined genetic abnormalities, you do not need a cutoff of 20%. And why did this happen? Ruvini, would you like to take up this question? Why did this major change happen that you don't need a cutoff of 20%?
I'm not sure, ma'am.
Okay. So what happened is, what they found was that patients of MDS with same translocation but having less than 20% blast behaved similar to AML with such translocations. So then there's no point in discriminating between these entities because they ultimately progress to AML and their treatment was delayed till the time they were categorized as AML. So why should they have same biological process and they behave similar. So that is why this cutoff was taken off. So apart from AML with BCR-ABL1 and AML with SEPA mutation, if you find all these other translocations, it is straight off classified in AML. Okay. So what is the importance of NGS? So apart from this NPM1 mutation, we saw two other mutations in this case. One was in DNMT3A and another NRAS mutation. So what is the importance of NGS in this case? Like by conventional PCR, we got NPM1 mutation. And what is the importance of NGS in this case? Ruvini, any idea?
Ma'am,
Sorry, I
as well.
lost.
Stated the DNMT
Yeah.
poor prognosis.
Correct. So, NPM1 mutated AML with DNMT3A mutation have a poorer prognosis as compared to NPM1 mutated AML without DNMT3A mutation. Multiple mutations play a role, and it is a complex mechanism per se. So, presence of DNMT3A or FLT3-ITD confers it to be a poorer prognosis. So that is why we in this is a publication from our lab where we have seen that according to risk scoring, different patients behave differently. So that is why it is important to identify other co-occurring mutations in these NPM1 mutated AML. So why was it important? Why was molecular testing important in this case per se? Clinically, what difference did it make? What's
Ma'am, on a treatment, because both having the different treatment, what we give on morphologically.
correct, correct. So yes, so both CMML and AML have difference in the treatment. That is why it is important per se. Okay. So I'm at the end of case one. Do you people have any questions for me
Yeah,
at this
I
time?
think there's a very interesting question, Shweta, in the chat box. So the question is that then should NPM1 be done in all cases of MDS and CMML? Because it doesn't matter, blast count doesn't matter. So should we do NPM1 in all MDS and CMML cases?
Yes, we have to. We have no other choice, ma'am.
Yeah, so I think that the clinical picture will also, of course, matter. So if it's an acute presentation, you will know that CMML or MDS is unlikely. So on those cases, you can prioritize. But Shweta is right. Like this AML defining genomics, probably you now have to do in all cases of MDS and CMML to not miss this low blast count cases of AML with defining genomics. Thankfully, they are less in number, but still you shouldn't miss them. Yeah. Okay, so I think I'll share my case now. Shweta.
Yeah.
Okay, so maybe Ayushi can take this. Ayushi, do you want to read out the history?
Yes, sir.
Okay.
So the case is 32-year-old male complaining of multiple cervical, axillary, and inguinal lymph nodes for 15 days. There is no history of fever, weight loss, or night sweats. CBC at the local place revealed normal hemoglobin. TLC was raised, leukocytosis, normal platelet count, and in DLC the significant reading was raised eosinophilia.
Okay, why do you say eosinophilia? What point do you say eosinophilia, Ayushi?
So when it is in the DLC, when it is more than 10%.
Okay, but what about the absolute count? Do we define eosinophilia based on just relative proportion, or we look for absolute
No, sir.
eosinophil count?
Based on absolute count.
Correct. So what is the cutoff usually?
Usually the cutoff is no, 2000 to 5000, sir. Normal range.
Are you sure? The normal range. What is the normal range of TLC that you see in adult patients, like the total count?
Sorry, sir. What is the
Normal range of total leukocyte count that you see in adults? What is the normal range?
4000 to 11,000?
Correct. So you said 2000 to 5000. So then 50% to is normal. Up to
No,
50%
sir.
eosinophil is normal.
That is less than 500 cells.
Correct. So less than 500 per microliter is what is normally seen. And for a eosinophilia diagnosis, we usually it is more than 1500, right? More than 1.5. So in this case, if you see the total count is 22.7, so 13% eosinophil will surely make it more than 2000. So yes, I agree with you. There is eosinophilia. But why do you say that eosinophilia is the only significant finding here? What about neutrophil is also slightly increased, no?
Yes, sir.
I agree with you that there is no immature like myeloid cell here in the peripheral blood, but yes, there is some neutrophilia as well. Okay, can you go on, please?
Further, the patient developed erythematous painful skin rash over bilateral lower limbs and conjunctival redness. The patient received antibiotics, cephalexin, cefoperazone, sulbactam, and doxycycline for 2 weeks. And he underwent cervical lymph node biopsy, which was suggestive of atypical lymphoid proliferation. On bone marrow aspiration, it was suggestive of panmyeloid hyperplasia.
Okay.
And further, the patient was referred to TMC.
Okay. What about the clinical examination?
In TMC, the clinical examination was left upper cervical lymph node, which was measuring 2 by 2 centimeter, right axillary lymph node 1.5 centimeter, and liver was measuring 2 centimeter below the right costal margin, and spleen was 3 centimeter below the left costal margin. On PET CT scan, the low grade metabolism in supra and infradiaphragmatic adenopathy was seen, with largest retroperitoneal node being 4.2 by 2.6 centimeter. The diffuse low-grade metabolism noted in marrow could be reactive.
Okay, so can I, take a pause at this point of time, Ayushi, and ask you, what are you thinking right now? Like this patient has presented with lymphadenopathy, right? Lymphadenopathy and fever.
Yes,
You know the counts. The counts are increased, as you said, with some eosinophilia, and there is some spleen and liver as well. So, what are your differential at this point of time? Even before, let's say, even before going into count, like lymphadenopathy, fever, and hepatosplenomegaly. So, what are the things that you are thinking in your head?
The patient might go into lymphoma.
Okay, lymphoma can be one possibility, surely. What else? Like when you see a patient in your practice or in your hospital with lymph nodes and fever, what other thing you think of?
Maybe tuberculosis.
correct? So tuberculosis and other infections as well, right? Like some viral infections and those.
Yes.
So all those things you have to think. Like at every point of time, try to think that what are the possibilities, and the clinical pictures needs to be understood very well. Like we have always emphasized, I think, in this OTPGP sessions, that the clinical context is super important for any diagnosis. So, okay, so I've discussed a little bit of thought process now. So this was the peripheral smear. Actually, this is very old. So, I apologize for the not very good quality of it. So can you tell me about these cells? Ayushi, what do you think these are? Like this one,
So these
and this one.
these seem to be the eosinophil cells
Can you describe them? Those
having by.
eosinophil cells?
Sorry, sir.
Yeah. Can you describe them? Yes, you are describing. Go on.
Yes, sir. The cells are showing binucleate bilobe nucleus.
Okay.
Moreover spectacular shape, and the granules are azurophoric granules. Moreover orangish red colored granules.
Yes, so they are eosinophilic granules, right? Like classically, we
Yes.
use the term acidophilic for neutrophilic granules. So these are eosinophilic brick red granules. The difference in
Yes.
color is not very evident here, as the slide is very old actually. All right, so maybe now Jhansi, we can discuss with you. This is the PET scan. We have summarized it already, so I'm not really going into too much details. Maybe we can ask Rovini, because she's, I think, a clinician. Rovini, can you tell me, like, what do you see in PET scan in a suspected case of lymphoma? What are the things a pathologist should know? Can you please talk about that?
Yes, sir. Depends
Yes.
on the increased PET avid areas with regard to the PET avidity in comparison with the liver,
Right.
whether it is high or not.
So you look
Especially
at
with
the extent of involvement, of course, and do you also check this SUV max? Like, how do you interpret that thing? Rovini, are you here?
I'm not quite sure about that, sir.
Okay, so it usually like SUV max, a higher SUV max will usually indicate that this is a high grade lymphoma. So in this case, it was mostly less than 10. All the SUVs were less than 10, but the level of involvement seems to be quite extensive, right? Like there is supradiaphragmatic as well as infradiaphragmatic involvement, and there is spleen and liver as well. So those are the things we have already discussed. So now we go to peripheral blood flow cytometry. Jhansi, can you tell me, like, what are these blue cells here? Like, just see the markers and tell me what are the blue cells. Because Sweta has already described about the, lymphocyte, monocyte, and granulocyte. So we are not going into too much details into that.
Blue
But can
cells
you tell me
are
what are those B cells? Yeah.
blue cells are CD19 positive B cells, sir, B lymphocytes.
Okay. Are they like B blast, or they are normal B lymphocyte, you feel? These things we're talking about.
Normal mature B lymphocytes.
Why? Very good. Why do you say mature?
CD20 and CD45 positive.
Correct. So these 20 and 45 both are quite late. They appear quite late in the B cell maturation. So they are nicely positive. So I don't think they are any precursor cells. So B cells seems to be quite normal, right? So let's go to myeloid now. So, Shweta has already described, like, how do we look at the normal and abnormal myeloid blast, right? So let's just say that this gates that you see here, these are the boundaries of normal, right? So what we do is, like, Shweta showed you one normal case and one abnormal case side by side. So then it is easy to understand. But in real life, like when a case comes to you, you are not probably going to have a normal control, right? So what we do is we kind of draw these gates on normal, and then we in a case we evaluate whether everything is within the normal boundary, so to say, or there is anything that's going out. So in this plot, like this plot, this plot, or this plot, do you see any abnormality, or everything seems to be well behaved? Jhansi?
They're normal within the gating, sir.
Correct. So just tell us what you see. Like don't need to don't overthink. So yeah, so like you said, within the gate, everything seems to be within the gate. So this myeloid blast also seems to be normal. So again, I'll also try to draw your attention to the fact that the percentage was very less, right? In the peripheral, but only 0.2% is myeloid blast, and this seems to be normal. So we saw the B blast, they were normal. The B cells, they were normal. The myeloid cells are also normal. So now let's go to T cells. So now maybe who can take this? Butts, can you take this? So what are these yellow cells you are seeing, Butts? They are just describe them and tell me what these cells you think they are.
Sir, these are CD3 positive
Correct.
with T cells. Are
That is true. So they look like normal T cell, right? They're surface CD3 positive and CD7 as well positive. So this looks like T cells. But now here we can see some cells which are 7 positive but surface CD3 negative, right? This particular gate. So surface CD3 negative and 7 positive. So what normal cell can be here? Do you know? Can you tell me? Like what cells in body are normally 7 positive but surface CD3 negative? Do you know? Anyone
sorry,
else?
sir.
Like
Precursor thymocyte cells.
okay, but would they come in peripheral blood in a huge number? No, no. Normally they should not be circulating in peripheral blood in such a good number. So any other normal cell that is 7 positive other than T cell that you know? Yes, somebody says something, I think. What about NK cells? What are the phenotype of NK cells?
16 and 56.
That is true. That is correct. They are 1656 positive. But what about their 7? Are they 7 positive or negative NK cells?
Positive, sir.
Positive, right? So these are NK cells. Like normally NK cells will come in this zone, which is 7 positive and surface area negative, right? So in our case, though, as you can see, we have gated this population. Like look at this gate. This gate is called 3 versus 7 NK. We have just named it whatever way we want. And we are now seeing only this population. So that is the beauty of gating, where you can just zoom into your target population and can take that into a next plot just to focus on that, right? So we have focused on that, and we see that there is a population of 5 positive cells among these, right? So do normal NK cell express 5? Do you have any idea about that? Maybe I can ask Lena. Lena, do you know? Like normal NK cells are 5 positive or negative?
No, sir, I don't have an idea.
Okay. So Ankit, can you help Lena?
Sir, they are normal are usually negative, sir.
That is true. So normal NK cells are CD5 negative. They can, in some reactive conditions, express little bit of dim CD5, but predominantly they are negative. So here we can clearly see there is a population of black cells which are 5 positive. So now my suspicion index is slightly higher. Like, are there some abnormal T cells we are dealing with? And then we go to the next plot. What is this marker, Ankit?
CD1A.
CD1A indicates what in the context of T cells? Like in the maturational pathway of CD1A, is it like positive in immature T cells or mature T cells?
Immature T cells.
Correct. So CD1 is usually positive in T blasts, right? So now I'm sure that these are T blasts, right? Because they are 7 positive, they are 5 positive, and they are 1A positive. So this is definitely T blast. And we'll further look at CD4 and 8 plot. So what happens in normal T cells in CD4 8 plot? Like what is the normal expression of CD4 and 8 in body? Positive, but you will see like a dual population. One will be 4 positive, one will be 8 positive, right? But our cells, they seem to be 4 positive, and then a very subset is 4 and 8 double positive, right? So this is now multiple abnormality. This is 7 positive, 5 positive, 1A bright, and 4 and 8 are double positive, or at least 4 is positive. So this is definitely abnormal. They look like T blast. And also this population was only in 0.06%. So now we are thinking like what's happening in this case. Like we thought this was the case of eosinophilia. There were some lymph nodes as well. But in here we are finding 0.06% abnormal T lymphoid blast. What about those eosinophils? We looked at with some markers. Let's not go into too much details, but there were some eosinophil as well. So almost around 10% was eosinophils. So from peripheral blood finding basically is 0.06% circulating abnormal T lymphoid blast with eosinophilia. So what now? Like what would you like to do at this point of time? Let's say you are handling this patient, and what would you do in this case? Whom should I ask? Maybe Ayushi, because she started this patient. So the patient has
So
lymph node. Remember Ayushi? Patient had lymph node, patient had fever, and now we are finding very small population of T blast in peripheral blood along with eosinophilia. What would you want to do next?
sir, I would go for FNAC of the lymph nodes.
Okay, FNSC of lymph node or lymph node biopsy as well, right? So those things
Yeah,
can be
lymph node
looked at
biopsy.
just to see what's happening there. So we did that. We did FNSC as IUC suggested. This population you can see of this cells, which looks like blast, right? Those is kind of blast-like cells were there. And on flow, who can describe this? Ankit, can you describe these red cells now? What do you think they are? Ankit, you're here?
Yes, sir.
Yeah. So just describe the red cells for me.
So these red cells, on one hand, on the CD34 and side scatter graph, that is the second plot, we can see that CD34 expression is very much diminished,
Yeah, it's negative. Okay. Then
negative,
what
and
about CD5?
CD5 expression is very much increased.
Right, it is positive. I will not say increase because you can see these yellow cells, right? These are normal T cells. So
Okay.
as compared to that, this looks like dimmer, but it is positive. Sure. Then
Again
what about
CD3
plus?
is diminished,
Yes. And 7?
and 7 is and CD7 expression is very much increased. I mean,
Right. Let's say positive. Let's not say diminish and increase.
okay,
Let's say positive. Okay. What about
positive. Yes.
1A?
1A expression is positive.
Very good. Again, like 4 positive and a subset showing 4 and 8, right? You will agree, right?
Yes. Yes.
Yes. And cytoplasmic CD3 positive. So do you see the same phenotype that we saw in peripheral blood, or this looks anything different to you? Ankit? The
Yes,
same
sir.
phenotype? This is the peripheral blood, remember?
No, sir.
This is
No,
what
sir.
we
It's
saw.
different. There is
How it
some
is
difference,
different?
sir.
How it is different, Ankit? Like, look at this 7 positive, 3 negative, 5 positive, 1A there, 4 8 showing
Okay.
this kind of pattern. Exactly same, no? When you go
Okay.
here,
Yes.
the
Yes.
7 7 3 is same, 4 and 8 is same, 1A is there, right?
Yes.
So the
Yes.
same blast population we can see, which we are picking up in peripheral blood in a very small proportion. So now what will be your diagnosis right now at this point of time? Remember, we discussed that these are T blasts, right? And this is the lymph node. So
Yes.
lymph node showing T blast. What is the diagnosis?
It's a precursor T cell lymphoma.
Precursor T cell lymphoma, right? So that is called T lymphoblastic lymphoma, right? So these are blast, and this is a T lymphoblastic lymphoma. Absolutely. So in this case, because the theme of our topic is how flow and molecular help. So if you just take a pause and think about it, because we did a flow in peripheral blood, we're able to pick up that very small population, right? So even if you do not say anything on that, but at least you know that this is now, I'm suspecting that there might be T blast, and then you can look at the lymph node and you can say that, okay, this looks like a T lymphoblastic lymphoma, right? So in this case, actually a biopsy was done initially before they came to us, and it was called as reactive. But when we in flow we said that this looks like T blast, TDT was performed on that biopsy, and that was positive. So this looks like a T lymphoblastic lymphoma, right?
Gaurav,
But in this case, yes, sir.
there is a question in the audience.
Yes.
Do we call
Yes.
blast on the basis of CD1A expression only as CD34 is negative?
Yes, so for calling blast any immature marker you need. So for T, actually, classically T blast are 34 negative. So 34 is not going to help you in cases of TALL in most of the cases. So in that case, 1A is useful, and yes, 1A at least tells you that these are immature cells. Now whether they are abnormal blast or not, you have to again look at the patterns. But in a peripheral blood or in a bone marrow, if you see 1A, so of course these are T blast only. Based on 1A, you can say that yes, these are T blast. So just think about it just like TDT. So if you see TDT positive blast in tissue biopsy, you are going to say that blast, right? You're not going to wait for 34 to say that these are not blast. Similarly, if you see 1A positive, you're going to say that they are T blast. You want to add anything, sir?
That's fine, Gaurav.
Yes. Yes.
There's a question in the audience. I thought you can, basically 34 negative can be blast. So
Yes.
do we do TDT also in flow? Do we do TDT?
Yes, we do, sir. But the problem is it is a nuclear marker. So means if it comes positive, it's nice. But if it's negative, we cannot totally exclude the possibility that it will be positive. So we don't give too much importance to TDT on flow, but we do in this kind of cases. We do. Right. But so now, Ankit, so this case, remember there was some eosinophilia as well. So how do you correlate all the findings? So you're going to label this T lymphoblastic lymphoma and stop there, or you want to do anything else? You want to do anything else in this case? Ankita, maybe Ayushi, because this is Ayushi's case. Ayushi? So now we have established the diagnosis of T lymphoblastic lymphoma. But remember that the patient had only very small blast in peripheral blood. And the predominant finding, as you said, was eosinophilia. So we're going to stop here, or anything else you want to do?
Maybe we would like to check whether there is bone marrow involvement or not.
Very good. Excellent. So we did a bone marrow. What do you think about the cellularity of this bone marrow, Ayushi?
For a 32-year patient, it is it is somewhat a normocellular bone marrow.
Are you sure? Like it looks to me that the cell bone marrow is packed almost. Like I can't see too much fat spaces. So
Okay,
means
yeah.
I would call it hypercellular,
Okay,
right?
okay,
So it
yeah.
looks like a hypercellular bone marrow. So this is the kind of differential that you can see here, right? So look at these cells. What do you see? Like, do you see blasts?
So there is one suspicious cell in the center.
Okay, I agree with you. What about these cells? This one, this one, this one, this one. What are they?
These are the band forms. So moreover, or more probably dysgranulopoietic neutrophilic cells.
Surely neutrophil lineage cells, right? Neutrophil lineage
Yes,
cells
sir.
for sure. What
Yes, sir.
about this, like this one here, this?
Eosinophilic, sir.
Correct. So that's what we saw there also, right? We saw lots of eosinophils. Remember in peripheral blood, we are seeing that in marrow as well. And can you tell me what these cells are? This one, then this one. What do you think? This one. Can you differentiate them from eosinophil? You can, right? These cells.
Yes, sir. Yes, sir.
Yes. What do you think they are? Again, this
No,
one
sir.
here.
No, sir, I don't know.
Yeah. So anyone else? Vats, Ruvini, Jhansi. Anyone wants to comment what these cells are? Very good. Why do you say they are mast cells?
Due to increased granularity, the staining take up.
Increased basophilic granules, right? And why not then basophil? Well, they can be basophil, right? If I say they are basophils.
In the tissue sections, we call it.
Okay, so in aspirate, usually the basophils they have more coarser granule, like this kind of granules, slightly finer in mast cell. You can see, and the shape also, like most of these mast cells looks to be like kind of spindle shaped, which is typical of abnormal mast cells. So those kind of things will help you in picking up mast cells versus basophil. So, but yes, it's still a tricky differential sometimes. But in this case, it looks like mast cells, right? So what do you think now? Like blast, it was only I think 1 or 2% in the bone marrow, right? Let's forget for one moment, Ayushi, that this case had T lymphoblastic lymphoma. Okay, so if this bone marrow comes to you, a 32-year-old male with a hypercellular marrow, looks to be myeloid preponderant. The erythroid are there present, but they are slightly less as compared to myeloid cells with eosinophilia, with some mast cells as well scattered. What is your thought process? Let's forget for a moment that the patient had T lymphoblastic lymphoma. What would you call in bone marrow in this case?
Maybe, sir, mastocytes.
Okay. Yeah, okay. Mast cells are increased, so you like to check those mast cells, they're abnormal or not. But let's say for one moment, let's say mast cells are also not there. Then this is the hypercellular myeloid preponderant marrow, right? With some eosinophilia. So this kind of picture you typically see in what kind of neoplasm? Somebody says AML M4. Why do you say AML M4? Like I can't see increased blast in this. So why AML? So what disease typically presents with this kind of picture, like a hypercellular myeloid preponderant bone marrow, eosinophilia, maybe basophilia as well. Count is increased in the peripheral blood. Spleen is there. So what disease typically present like this?
Maybe MPN.
Very good. Yes, MPN like CML, those kind of things present like this, no? MPN presents with splenomegaly, high count, hypercellular myeloid preponderant bone marrow with some eosinophilia. So in marrow, it looks kind of like MPN to me. It looks like MPN, isn't it? So it could be an MPN. So this is the bone marrow biopsy. I think we're slightly running out time, but again, we can see a hypercellular myeloid, like hypercellular bone marrow in this PAR, right? Hypercellular bone marrow, some scattered megakaryocytes we can see. This is the picture. Again, you can see some eosinophils here, some eosinophils, they are present. Some erythroids are there as well. It's not that it's very myeloid preponderant in this. It's a hypercellular bone marrow, but blast, I can't see like too much blast cluster. It's a case of T lymphoblastic lymphoma, but we can't see too much blast cluster on the bone marrow, neither in bone marrow aspirate nor in bone marrow biopsy. We did a flow as well, and similar population of T blast we could identify in 0.17% only. So again, it's not the predominant finding in bone marrow, but they are there. Those T blasts are still there. So this now looks like a crossroad, right? Like, can you think of anything which will explain the full picture? Like there are T lymphoid blast in lymph node. There are an MPN-like picture in bone marrow. So what's going on? Let's just see. This is a single patient, right? It's not that we are seeing two patients thing. So what do you think? Like, do you know about any disease that can kind of explain all these findings? Yes, Ayushi?
So maybe myeloid lymphoid neoplasms.
Okay, that's true. Yes, that I will think of. But what about a common condition like MPN which can present with lymphoid blastocysts? Can CML present with lymphoid blastocysts?
Yes, sir.
Yes, of course they do. So of course we'll think about CML first. The CML would be a differential for sure because we have MPN like picture and we have T lymphoid blast in the lymph node. So CML first, and then yes, you're right. Myeloid lymphoid neoplasm with eosinophilia will also be thought of. So we did some cytogenetic analysis. As you can see, it's very expensively done, and BCR-ABL was done first, and it's negative. So now still is CML a possibility?
Possibility, yes, it can be with BCR-ABL negative.
The definition of CML is BCR-ABL positive, but I think what you're meaning is by FISH it might be negative and we might pick up abnormality in PCR, right? Like a cryptic fusion.
Yes, sir.
But let's say this
Yes,
is negative for everything. BCR-ABL is negative by all techniques. So
we
then
can
this
rule out
can't be CML, right?
Yes, sir.
Right. So CML ruled out. Now what are the things left? Ayushi, Ankit, anyone? But so you said already myeloid lymphoid neoplasm with eosinophilia, right?
Yes, sir.
So for that, what technique would you do? How will you pick them up? So what are the fusions that are present in myeloid lymphoid neoplasm with eosinophilia that you know of?
So PDGFR-A, PDGFR-B, and FGFR1.
Very good, very good. So how do you pick them up though? So in this cases the problem is that this neoplasm, like maybe except PDGFR, all the other fusions they have multiple gene partners, right? So it's very difficult to really put proofs for all of them in cytogenetics. So you need sophisticated techniques for that. So we have done RNA sequencing in this. So this is the technique that we have developed in our lab called Narsima. But the basic goal of this technique is if we know one of the partners, which in this case is ABL1, we use an universal primer in the other end. So therefore, we can pick up any rearrangement of this case. So for example, if it's ABL1, it will pick up BCR-ABL1, it will pick up ETV6-ABL1, all host of ABL1 fusions. So that is the principle of this RNA-seq technique. We did that and we found this fusion, which is known as ZMYM2 FGFR1 fusion. This was confirmed using reverse transcriptase PCR as well. You can see this band here in this case. So this indicates that this fusion has taken place, this ZMYM2 FGFR1. So then now what is the final diagnosis in this case? Ayushi.
Sir, it is myeloid lymphoid neoplasm with FGFR1 rearrangement, along with the eosinophilia.
Very good. So that's the diagnosis. So I hope that at this point you can understand like how flow and NGS has helped in this case, right? So using flow in a case of lymph nodes and fever and eosinophilia, we could first pick up that yes, there is some small T blast in peripheral blood that made us look into lymph node, look into bone marrow. We saw that yes, this is the T lymphoblastic lymphoma. But then in bone marrow, we see that eosinophilia and MPN-like picture is predominant. So now we think that, okay, so maybe T lymphoblastic lymphoma is not the whole picture. We're going to do something else. And we did this and we found out this particular fusion. So as you have said, this is a group of neoplasm now recognized in WHO. It was recognized in WHO4 as well, but in WHO5, now we have a host of fusions. So you spoke about PDGFR-A, PDGFR-B, FGFR1. Now we know there can be JAK2 rearrangement as well, FLT3 rearrangement, ETV6-ABL1 fusion. So these things can also be present. Same thing actually. So this is a host of fusions that can give rise to this kind of pictures. And okay, so at this point, like let's take a very quick detour. So just look at these cells, right? So if all of you, please look at these cells. Don't say anything. Don't describe anything to me. Just look at these cells, okay? This is a 33-year-old male presented with high TLC, bone marrow aspirate showed this kind of picture, okay? Just look at these cells, maybe look at this particular cell as well. This one. Don't describe. Don't say anything to me. And this is another field. Let's assume that this is a representative field. So now can you tell me that what is the proportion of eosinophils to neutrophil in this case, you think? Maybe we'll start with Ankit. What do you think, Ankit? And please, audience can write in chat section. What do you think is the eosinophil percentage and what do you think is the neutrophil percentage in this case? What do you think, Ankit?
So eosinophils are less than 10%, predominantly
Okay.
neutrophils.
Uh-huh. There is Rishita in chat box says 1:1. So she says 50% eosinophil. Okay. What about you? What's
Yes, sir. 30 to 50, between 30 to 50.
30 to 50%? Okay. Ayushi?
Less than 10% eosinophils.
Okay. Ruvini?
Eosinophils, 10 to 30%, sir.
10 to 30%. Anyone else like Jhansi?
10 to 30%, sir.
Lina?
So 10 to 30% eosinophils.
Okay. Whom am I missing? What's No, I think Vats has already
It's a
spoken.
30
So
to
whom am I
50%.
missing? Yeah, I think I missed one student. Whom did I miss?
Sir, Aishwarya,
Aishwarya, yes. What do you think,
that
Aishwarya?
10 to 30.
10 to 30. Okay. So in this case, we did flow, and this Siglec-8 is a marker specific for eosinophil. And ultimately, we saw that there is 85% eosinophil in this case. So, sometimes they can present with extreme situations. Go back to this. Look at these cells. This is an extreme example of an hypogranular eosinophil. There's no granules. Granules is completely gone. But still, you can see this kind of bilobe nuclei of an eosinophil, and they look different than these neutrophils, right? So this neutrophil, if you see the cytoplasm, and their nuclear lobation, these cells look different, right? So this is actually an eosinophil, dyspoetic eosinophil, we can say, because it is hypogranular. Again, here, this cell, this cell, this cell, these are all eosinophils. In this case, actually, there was 80% eosinophil, and when you did RNA sequencing, this came out to be a PDGFR fusion eosinophilia. So, what is the importance of this diagnosis? Okay, biologically, they are very interesting, right? So, like we have discussed, lymphoma at one side, MPN at the other side, and we can kind of join them together with one particular fusion. But the more important thing is that some of them are very much treatable. Like for example, PDGFRA, they respond exquisitely to imatinib. So in these cases, we do only 100 milligram imatinib. Do any of you know like what is the starting dose of imatinib usually in CML patients? Rubini maybe can answer that. Rubini?
In CMS, 400 milligram imaging.
That's true. So in CML, we start with 400, but in this PTGFRA, they are so much sensitive to imatinib. Even 100 milligram dose is good enough. So, this is a neoplasm which is even more sensitive to imatinib than CML. So that is the reason why we want to pick them up. And like clinically, they can be challenging to identify. As we have seen, they can present with extramedullary blast crisis, present with MPN-like picture. They can sometimes present with upfront AML-like picture with a myeloid blast phase and an extramedullary myeloid sarcoma as well. But you will have some clue at least. You'll have eosinophilia. You will have, some lymph nodes showing some blasts. So those kind of things you should be using to pick them up, and then you use flow and molecular techniques to correctly identify them. I'm going to skip these slides. Yeah, so in an evaluation of eosinophilia, you start with the basics like morphology, you do clonality of T and B cells, immunophenotyping, and all this clinical investigation like CBC, monocyte count. You check for organ involvement. So when all of this done and reactive causes are excluded, then you have to really do this test at today's date, like test like RNA sequencing or FISH, because that will be able to identify this host of fusions, and some of them they do respond to specific therapies like PTGFRA, B2 imatinib, ABL1 rearrangement to dasatinib or nilotinib. So that is the reason why you cannot say that we will not be able to pick them up, because you are then going to give the patient a therapeutic opportunity with this kind of therapies. So with this, we will stop this case and we'll go to our case 3, I think. So if any question is there, we'll take it right at this point of time.
So Gaurav, the conclusion is eosinophilia, ALLs can present as eosinophilia.
Yes, they can. ALLs can present, and there are those cases you have to think that what are the underlying fusions, and it may not be just a routine case of ALL, and we have to look for other features as well. Anything in the chat section?
I think one question was there, why can't it be inversion 16? So the previous case.
Yeah, so it can be. I mean, I'm not saying it can be, but we have proven that it is not because we have done inversion 16 and shown it is negative. But what is unusual for inversion 16 in this case is a T blast. First of all, they usually do not present with a lymphoma kind of picture and with the T blast in lymph node. So they usually do not present with that. And even in flow, you will be able to pick up the abnormal myeloid blast and those monocytic expansions. So they were not present in this case. But again, in this kind of rare situations, you cannot say that this can't be it. So you have to do it and prove that it is not the case.
Right. Apart from that, I think questions are done. So we'll move to case 3 now. Students, if you have any questions at this point, you can ask for case 2.
Did you understand like how flow and NGS helped in this case to reach the ultimate diagnosis? So we talk about this concept in our lab that taking a case to the home, right? So this is how you take a case to home. Means you give it a proper diagnosis. So sometimes those are challenging. Like it can't be done in one day. You have to think the whole spectrum of the case. Like in this case, the first peripheral blood came to us. Then we did lymph node. Then we did bone marrow. Then we did molecular in the lymph node. So everything it takes some time sometimes, but you have to think that I have to take this case to its diagnostic home in these situations.
So we go to case 3 now. So case 3 is something, a breather kind of case. So it's a relatively easy case. So what would you like to read the history?
Yes, ma'am. On clinical history, a 65-year-old male, seropositive, presented with the neuropathy, subcutaneous nodule, and easy bruising. And on CBC, hemoglobin 8.1, TLC count is 12,000, platelet is 1 lakh. And on SPP, it shows the M band, and on IFE, it shows the IgM kappa by immunofixation.
Right. So we have in 65-year-old male, we have seropositivity with some neuropathy kind of picture, anemia in the patient, mild raise in leukocyte count, and M band in serum protein electrophoresis, which is clonal by immunofixation, right? So what do we see in the bone marrow aspirate morphology here? Ayushi?
And here the two cells are shown which are having E-nucleated, E-centric nucleus, and along with the cytoplasm with showing slight most probably it is going towards lymphoplasmacytoid cell.
Perfect. So lymphoplasmacytoid cell. Aishwarya, what is this cell here?
Ma'am, this is a plasma cell. It shows
Perfect.
eccentric nucleus and it has a half also.
Yes. So this is a plasma cell. In the previous slide, we had seen lymphoplasmacytic cells. So what are we thinking of diagnosis based on bone marrow aspirate morphology, Aishwarya?
A plasma cell neoplasm.
Plasma cell neoplasm. So do you mean you're thinking of multiple myeloma kind of picture?
Yes, ma'am.
Multiple myeloma kind of picture. Okay. Okay, fine. So let's go ahead and look at flow cytometry. Okay. So can you describe what are your findings in this case? What are these cells here?
This shows the CD20, CD19 positive B cells.
B cells, okay. And if we look at the 38 plot, are these coming in plasma cell category? Like, uh, are they plasma cells here by flow cytometry? These cells? Jhansi, what do you think these cells are? Blasts. Why do you say blasts? I'm sorry, I have not given CD45 for this case. So I say 45 is bright for this case. So will they still be blasts? In morphology, we had seen lymphoplasmacytic cell, a proper plasma cell, and and we are seeing 19 bright, 20 bright population, which is marked in red. Okay.
And light chain
So,
restriction. And
sorry, sir.
light chain restriction also.
Yes, sir.
I said the light chain restriction also is there. Kappa is there.
Yes, yes. So in kappa lambda, these cells are showing kappa positivity. So what kind of cells? I'm saying these are 45 bright.
CD38 is positive, ma'am.
Okay, so we
So
see
they're more.
three kind of population here. Okay,
Yes, sir.
the red population that we are seeing here are they 38 positive or negative?
They are negative, ma'am.
Okay, the black population that we see here, are they 38 positive or negative?
Those are CD38 positive, ma'am.
Okay, and these purple population, what are these purple population which are 38 bright? What do you think these cells are? 38 bright.
Plasma
Maybe.
cell, ma'am.
What are markers for plasma cells?
CD38 and 138.
Yes. So if we are thinking of multiple myeloma, those would be 38 and 138 positive. But if we see predominant population here is actually 38 negative with a maturation trend going towards 38 positivity and going towards plasma cells. So we see a trend of these 1920 bright population of lymphocytes that are maturing towards plasma cell. And in the bone marrow aspirate morphology also we had seen actually the cells were lymphoplasmacytic cell with few plasma cells. So we with this history we actually think of lymphoplasmacytic lymphoma and not multiple myeloma. Okay, and they are also showing surface immunoglobulin restriction. This is not cytoplasmic, but this is surface immunoglobulin kappa positivity. Okay, in multiple myeloma, we see cytoplasmic immunoglobulin, while in lymphoplasmacytic lymphoma, we see surface immunoglobulin positivity, like kappa positivity or lambda restriction. We can see any of these. Okay, so this is a lymphoma that is 5 negative, 10 negative lymphoma, and it is showing a trend of maturation towards plasma cell. Okay, so we can see that both this red population that is there, that is 38 negative, as well as this 38 dimmer, moderate kind of population that is also showing kappa restriction. So both these population are clonal in nature. So based on morphology and immunophenotype, we have a diagnosis of actually lymphoplasmacytic lymphoma. And how do we confirm it? So to confirm it, we have done allele specific PCR for MYD88 L265P. Here, what happens in allele specific PCR? Anyone knows about it before I explain it? Anyone has any idea of it? Okay. So what happens in this case is we are using a common forward primer and we are using two different fluorescently labeled primers for wild type and reverse type. Okay. Sorry, a mutant type. Okay. So what happens is in presence of mutation of MYD88 L265P, this mutant primer will go and bind to the site and give a product. While in the absence of mutation, only wild type peak will be seen. So if we go for the PCR capillary, we see peak in wild type as well as mutant type. That means there is presence of mutation, that is L265P in this case. So this case is actually how will we diagnose this case? What will we diagnose this case as?
Walden's.
Aishwarya?
Lymphoplasmacytic lymph with
Okay.
with MYD 88 L 265P.
Right. Okay. So, and there was presence of M band also. So, Do we have any specific term?
Waldenstrom's
Yes.
micro.
Perfect. So this was a simple case where we had a clear-cut diagnosis, and this is a case of Waldenstrom macroglobulinemia because along with LPL in the bone marrow, we had IgM component of monoclonal protein. Now, apart from MYD88 mutation, another mutation that has become important is CXCR4 mutation that may be present in up to 40% of cases of MYD88 mutant kind of LPL. And why it is important? Because in the presence of this mutation, these patients become resistant to ibrutinib therapy. So this is importance of this mutation. So along with MYD88, we also test for CXCR4 mutation. Okay. So with this, I come to the end of case 3. Any questions?
No, I think like people have mentioned about the markers of plasma cell, but I can't see any question yet.
Right. Okay. So, Gaurav, you can go ahead with the fourth case study.
Yes. Okay, just give me 1 minute. Right. So, okay. So now, whom do we go to? Maybe Lina, can you take this?
Yes, sir.
Yes.
Sir, a 41-year-old female, no family
Mm-hmm.
history of cancer, no past history of any malignancy, no
Mm-hmm.
known comorbidities. Uh,
Okay.
she had uh, she had swelling over left neck for 2 months, similar swelling over bilateral groin since 2 weeks, and intermittent fever since 1 week.
Okay. So again, some lymphadenopathy and fever, it seems, right? What about the examination finding?
Sir, what is this PS1?
So this performance status, right? So whenever a patient comes, usually the clinicians will write about the performance status. Like this is a good performance status, like whether they are ambulatory, whether they need any help, whether what is their like performance status at this point of time. So that is what it is. What about the lymph nodes? You can go ahead with the lymph nodes.
In the neck, multiple enlarged lymph nodes in bilateral level 1B to 4th and enlarged bilateral supraclavicular lymph node. On per-abdominal examination, liver was palpable 4 centimeter below the right costal margin and spleen palpable 4 centimeter below the left costal margin.
Okay. So again, like kind of the picture, we have already discussed the differential of this in the last case, right? So if you see lymph node and hepatosplenomegaly and like fever, so what are the thought process? So we discussed about lymphoma, tuberculosis could be a possibility, maybe viral infection, so that's also a possibility. So those lines we have to think. Even leukemia, like last case we saw it, like it was a lymphoblastic lymphoma. So leukemias can also present like this kind of picture. So now let's say we go for okay, so there's another thing here. Yeah, you can describe this slide as well.
Sir. On chest X-ray, bilateral prominent bronchovascular markings suggestive of allergic or infective etiology. On USG neck, there were multiple enlarged bilateral lymph nodes, largest measuring 4.3 into 1.3 centimeter at right level 2. On
Okay.
FNAC, right side level 2 neck nodes uh, were reported as reactive lymphadenitis.
Okay. So now, what investigation you will first do in this case, Lina? This is the
Sir,
patient. Let's not consider about the X-ray and all right now. So again, lymph node, fever, hepatosplenomegaly. What first?
uh, So we can examine the complete blood count and
Absolutely. So I have not given you the count yet. So that's the first thing you have to check, right? So, this case I have just given exactly like it came to us. So you can just talk about hemoglobin, platelet, and WBC count. You can see them, right? This is the hemoglobin thing. What do you think?
still the
This is the hemoglobin.
9.8. Yeah. Okay,
Yeah.
sir.
So it's
Sir,
on the
it's
lower
9
side,
point
right? Not too low, but
lower
still
side.
in the lower side. Platelet?
Uh, the platelets, sir, it's normal.
Okay. What about WBC?
WBCs are slightly higher,
Uh-huh.
only slightly higher, and
Yes. Yes. And this is the differential count. What do you see here? Is it normal or is there any problem in this?
Sir, almost normal.
Okay, so not too much significant finding we could see here, right, Nina?
Yes, sir. Yes, sir.
What about the biochemistry? What's there happening? Like, do you want to point out anything or it's okay, normal?
Sir, urea is low and creatinine and sodium are low and
Mm-hmm.
proteins are high, 9.31, and
Which
serum
of the protein
albumin.
component is really high?
Sir,
Albumin or globulin?
globulin is high. Globulin.
Yes. So what is the normal value of globulin?
Sir, 1.7 to 3.5 gram per
Very
deciliter.
smart. Yeah, I know it's given there. Very smart. So this patient seems to have some high globulin, right?
Yes, sir.
Okay. So do you know any causes of high globulin? Can you think of anything? Like let's a general discussion, not in this case. What are the causes of high globulin count?
Uh,
Any reactive condition, any malignant condition?
myeloma.
Myeloma, of course, yes. And in the last case also the LPL, those like Waldenstrom, that can also have high globulin, isn't it? And in
Yes,
reactive
sir.
situations,
Uh,
yes, somebody says flat muscle dystocia, definitely true. Anyone else like
lymphoma.
Aishwarya? I think I've not asked Aishwarya too much questions last time. Aishwarya? Aishwarya, you can think of any other cause of high globulin? Okay, maybe I can't hear Aishwarya speaking. Aishwarya, you're here, right? Yeah. Okay. Let's move on. Let's move on. It's okay, fine, no problem. Yeah. So at this point of time, what next would you do, Lina? This is your primary case. What next? Counts more or less seems normal. Like you said, the hemoglobin is on the lower side, globulin is high, the differential count and total leukocyte count seems to be on the normal range. And remember, the patient has lymph node, fever, hepatosplenomegaly. What next?
Sir, as we have already done the FNAC, we can
We can go for
immunoflo
lymph node biopsy, isn't it? Like patient has lymph nodes, patient has fever, so lymph node biopsy you will like to do, right?
yes, sir.
So actually, it was done outside as well. I will show you some pictures. I have some pictures of it. But in outside, the differentials were of follicular lymphoma and florid hyperplasia with germinal centers, and they did IHC, and it was suggestive of reactive follicular hyperplasia. Okay. So this is the PET scan again. Again, let's not go into too much details, but again, you can see the involvement level seems to be extensive, right? The cervical is there, axillary is there, mediastinal lymph node is there. There is infradiaphragmatic as well, like abdominal, retroperitoneal, some FDG uptake in spleen. So the involvement seems to be quite extensive, and on the tissue biopsy, it seems to be reactive versus follicular lymphoma. So this is the lymph node picture. Do you want to make any comment on this on low power? Let's say this. What do you see here? Maybe I can ask Vats. Vats, do you want to comment?
So seems like some germinal center are more, so follicular hyperplasia. And there is
So these are the
interfollicular
germinal
area
centers,
is
right?
also.
Okay, so
Yes,
you are
sir.
seeing some follicular hyperplasia here. What about the capsule and all that? Those are intact, like this one.
Capsule is intact.
Yes, you're right. I kind of agree with you. Here's another germinal center here. Let's go into details. So this is, again, some areas of germinal centers, as you can see here. This one as well. And this is what you are finding within the germinal center. You want to describe this? Like, what are you seeing here within the germinal center cells? What's
So predominantly lymphocytes are there.
okay?
Centrocytes are also, some are centrocytes.
What about these things like this one, this, this one? What do you think they are?
Mm,
Anyone else? Ankit, what do you think these cells are?
So these are high endothelial venules, means sinuses.
Okay. But would you call them abnormal at this point, or what do you think? Like, yes, I agree with you. There are some hydrothermal venules there, but would you say this is abnormal, this picture? Would you diagnose lymphoma on this? Is the question basically. Ankit,
Yes, sir.
would you diagnose lymphoma right now? What is the diagnosis now, till now?
It's a follicular hyperplasia only.
Correct. So follicular hyperplasia is definitely a strong differential here. This is some of the interfollicular region that I'm showing you. So they also had some of these endothelial venules. Background cells, but it's not too much. Maybe there is some atypicability, but it's very difficult to confidently level this case as lymphoma in this kind of picture, right? So it was more or less reactive condition was a strong differential in this. So then we received the bone marrow in this case. So yes, is there any question? Okay, so we received a bone marrow in this case. You want to describe this bone marrow, Ankit? What do you see? What are these cells? This one, and this, and this. Ankit, what do you think these cells are?
So these are these cells, they look like megakaryocytes.
Yes, yes, of course they're megakaryocyte. Here also you can see some cellular marrow and some megakaryocyte in this part. And when we see on the higher power, there are some erythroids, right? These cells are erythroids. You see some neutrophils as well. So do you see any obvious abnormality in this? Anyone else like births? Do you see any abnormality births? Yeah, there may be occasional scattered blast like cells, but that it's there in normally in the marrow, right? It doesn't seems to be the predominant finding to me. Even in bone marrow biopsy, it looks like a normocellular marrow with some scattered megakaryocyte there, erythroid lineage cells and myeloid lineage cells. So not like obvious gross involvement again, right? Even in bone marrow biopsy. So till now, we haven't been able to really pinpoint to any diagnosis, any confident diagnosis in this case. So in all this kind of bone marrow cases, we do flow cytometry to look for low level of involvement, right? For staging bone marrow. So we do that. Like it came to us as a lymphoma, suspected case of lymphoma. So we did staging bone marrow. So I would request your attention to this plot. So let's say these cells. What do you think these are? Ankit can take this maybe. This is surface CD3 and this is CD5. So what are these cells, Ankit? This brown color cells? What do you think they are?
They are both CD3 and CD5 positive there.
Yes.
This
So
means they are
what are
T
these cells then?
cells.
They are
T
T cells.
cells.
Exactly. And now we have something very interesting here. Look at these black cells. This is 5 positive, but surface CD3 negative, right? So surface CD3 negative, we have discussed last case, it could be NK cells, but they are usually 5 negative. So this is again 5 positive. So what's happening? Like 5 positive surface CD3 negative cells. And when we look at with 4, we see that even 4 is positive in this case, right? In these cells. So we have a very small population that is 5 positive, surface CD3 negative, and 4 positive. So we did some additional markers again. It's okay, almost the same. 4 restricted, 1656 negative. So clearly proves that these are not NK cells for sure. This small population of cells. And we could also see another population of cells. So here you can see this black thing, which we have already discussed, 5 positive and 3 negative. But even within the surface 3 positive cells, there is this red population. Do you want to describe them, Ankit? What do you see here? What is the abnormality of these red cells?
These red cells, they are CD3, CD4, CD7, 10. So many markers, they are positive.
7 positive, would you say? This is 7, right?
Oh, sorry. 87. They 7 negative. No, 7 is
Yes.
not
So
positive.
if they are normal T cells, like we are counting the abnormality here. What are the abnormalities? Abnormality is 7 is negative, first of all, and then CD10 is positive, right? So do normal T cells express CD10?
No.
Ankit? So let's again general
No.
discussion. We're taking a lot of detours in this because we don't want to restrict our discussion to only this case. Can you tell me what are the some cells that are CD10 positive in the body? What are the cells that are CD10 positive? Or anyone else can join in actually. Yes,
B
you were
cell.
saying that.
3B
Which cell?
pre-T cell,
B
immature,
cell.
immature B
PB.
cell T cell.
Very good. So immature B and T cell, very nice. And then like in the journey of B cells from the immature precursors when it becomes a mature plasma cell, is there anywhere else that it becomes CD10 positive other than the precursor stage?
Germinal centers
Very good. So germinal center cells are also CD10 positive, right? So CD10 can also be used as a germinal center marker. So now this T cell seems to be CD10 positive and 7 negative. So we have at least two different abnormal T cell population. One is 5 positive, 4 restricted. and 3 negative, and the other is 7 negative but 10 positive. So yes, a lot of complexity again. We don't know what's really going on. So we did some additional markers in this. I will just tell you what it is. This 278 is known as ICOS. That is a marker of follicular helper T cell. And 185 is again CXCR5, another marker of follicular helper T cell. So they were positive in this case, as you can see here. We will go on. We'll again move on. So at this point of time, what we did is that we told clinicians that it looks like there is some abnormal T cell, but the population is again very small. We cannot really confidently say anything. So we would again request for an FNSE flow, right? So from the lymph node, we want to see what's happening. In the lymph node, if we see the same population, we might be more confident to call it lymphoma. So we asked for a lymph node FNSE. And the lymph node FNSE came to us. I will just go through this very rapidly. So these are 1920 positive B cells, right? These cells now we are focusing on. What are these cells you think, Lina? Lina's case this is. 1920 positive, what are these cells?
The B cells.
B cells, and we checked kappa and lambda, right? So that is how you check the clonality of B cells. So what do you think? These B cells are normal or abnormal?
They are both kappa and lambda. So,
They are both kappa and lambda. There is an equitable distribution. So it looks like polyclonal B cells, right? So B cells are normal. Oh, that's done. And I now look for T cells, right? So T cells, again, we saw that the same population that we saw, no? Like surface 3 positive. This red population, please focus on them. They are 4 restricted, as you can see here. They are little bit of CD10 is positive, like we saw in the bone marrow. CD279, again, this is basically PD1, another follicular helper marker. That's very brightly positive, right? Very nicely positive. And what about this? Like, Vats, can you just take this plot? Like, what do you see in this plot? What is this marker? Some TRBC1. What do you know about this? Have you heard of this marker, Vats? Yeah, so at this point, let's take a detour and discuss the concept of TRBC1. The reason I want to do it is because this is a very useful marker. With a single marker, you can understand T cell clonality, which was not really possible like a few years ago, but now this marker has come. So how this works is this T cell has a beta chain, right? The T cell receptor has a beta chain, and there is this constant region of this beta chain has 2 conformation, either TRBC1 or TRBC2. So all that, if you take any random collection of T cells, right, random collection of normal T cells, what will happen is they will be either TRBC1 positive or TRBC2 positive. So that is TRBC1 negative basically. So you'll have 2 different peaks. One shows you TRBC1 positive, other shows you TRBC1 negative. But in case of lymphoma, what you will see is they will be restricted for either positivity like this, restricted completely for positive, or negative, because negative means that they are probably positive for TRBC2. So we don't have that TRBC2 marker yet, but negative, if they're completely negative, we can identify that they are also clonal. So think of it this way. Look at this plot. Like this is the normal T cells. They are showing equitable distribution of TRBC1. Some of them are positive, some of them are negative. Whereas our tumor cell in this case, they were completely negative. So that shows that they are clonal. So an analogy can be drawn with surface kappa and lambda light chain that we see in B cells, right? So let's say this example. This is another case that I'm showing you. So in this case, see the normal B cells. Like in this case, Lina has told me that B cells were normal because they were kappa and lambda, equitable distribution was there. Whereas if we have a clonal B cell, like for example, this was the case of, I think, a mantle cell lymphoma, you can see that they are restricted for completely for kappa, right? But what if we did not have lambda? So what we did, what we would have done is we would have looked only for lambda and say, okay, so normal will be half positive, half negative, and abnormal will be either completely negative or completely positive. So that's the situation in TRBC1. And normal will be either half positive and half negative, whereas abnormal will be either completely negative or completely positive. So in our case, it was completely negative, indicating that these T cells are clonal. They are definitely clonal. Okay, so let's go back to our case now. We have discussed the concept of TRBC1. So in this case, again, the abnormal T cells we can see 4 restricted, 10 positive, PD1 very bright, some amount of 10 is there. Some additional markers we did, like this ICOS. ICOS is also positive little bit. So now can anyone tell me the diagnosis? What is the diagnosis now? Lina, can you tell me? What are these markers like 10, ICOS, PD1? Have you heard of them in the context of T cells? What do they indicate?
no, sir.
Okay, that's not problem at all. Ankit or Vats, anyone else? Aishwarya?
It is a T follicular helper cell lymphoma.
Who is this? This is Lina, is it? Anyway, you're right. You're completely right. So this is looks like a T follicular helper cell lymphoma or nodal T follicular helper cell lymphoma. So if you just look at the way these things are classified these days, that this is a group of lymphoma that has this phenotypic feature and gene expression feature of T follicular helper cell or TFH cell. Previously, we used to call them based on their morphology, like either AITL, or that is angioimmunoblastic T cell lymphoma, or follicular T cell lymphoma, or a nodal PTCL with TFH phenotype. But now they are all grouped together and in WHO 5 as nodal TFH lymphoma. And then you will just say what is the morphology. Like they can be either angioimmunoblastic type, or they can be follicular type, or they can be NOS. And these are some of the markers of this group, like TFH group. And usually the diagnosis requires at least two markers. So in our case, 10 was there. Our case, PD1 was very bright. ICOS was there. CXCR5 was there. So definitely our case fits the definition of a TFH lymphoma. So therefore, this is a case of TFH lymphoma. Now, yeah, this is the same thing. It all comes under total TFHL, and then you can say some of them will be angioimmunoblastic type, some of them will be follicular type, and some of them will be NOS. So okay, maybe we'll just skip this slide. This is just to show you what is the normal role of TFH cells in the germinal center. You can see here that these cells usually stay in the light zone. This is the light zone. Remember, the FDC, the follicular dendritic cell, occurs in the light zone. And what they do is they give a necessary survival signal to those B cells that have a good affinity towards some antigen. So that those B cells are selected for maturation. And then they will again go back to dark zone and again go to the process of clonal selection and again will come back to the light zone. So these TFH cells are very essential in normal anatomy. Like they give the necessary signal to B cells, like which B cells should be selected and which B cells has a more antigen affinity. And that is how they contribute to our normal physiology. And yeah, so same slide again. So in this case, the differential of us was the problem. The reason why I described this case is because this AITL and this nodal TFH lymphomas can present with variable morphology, right? And sometimes their differential diagnosis is with a reactive follicular hyperplasia, like it was in our case. So one of the way to differentiate it could be that this PD1 positive, CD10 positive T cells usually spill over to parafollicular region, to paracortex in nodal TFHL lymphoma, whereas in reactive follicular hyperplasia, they usually do not. But this can be really challenging to pick up in morphology, and sometimes the morphology can be confusing with classical Hodgkin lymphoma, sometimes with even B cell lymphoma like DLBL. So also then these cases, flow cytometry and phenotype will really help in this case. So if you just think about it, like how does flow help in this case? This is a recent study we did on our group of T cell lymphomas where we did flow, and we could see that AITL is actually a very large number of T cells that occurs in our center. Like almost 22% of T cell lymphomas were AITL. Remember, these are not really all T cell lymphoma. This is the all T cell lymphoma where flow was done. So it may be slightly biased, this cohort is, but still 22% seems to be a quite high number. And what's more, like these cases are prone to be misdiagnosed. So if you see this here, so this is basically means agreement with histology. This is inadequate typing on histology. This is inadequate diagnosis on histology, and this is misdiagnosed. So see the number, it's quite high in AITL. So almost like 15% and 9% cases were inadequately diagnosed or misdiagnosed on histology. So this is the case, this is a situation where immunophenotyping and flow cytometry can really help in this kind of situations. So yeah, so that therefore the diagnosis, as you have rightly said, is nodal TFH lymphoma. So any further investigation that we can do, actually, we can stop the class here. Whatever you wanted, you are required to know is done. But now we'll just discuss 5 minutes of very interesting biology. So can anybody tell me like what are the other things that we can do in this case, in a case of nodal TFH lymphoma? Maybe somebody in chat section is also okay. Ankit, Vats, anyone can comment?
Molecular.
What molecule would you look for, Vats? Like, do you know the molecular picture of nodal TFH lymphoma? Okay, so let's not go too much into it. We did an FFP. Let's just right now just switch off. Just don't think that you need to know this. But just because I find this very interesting, and I think you should just know it for the sake of getting interested, getting fascinated by the subject. So let's see. We did an FFP tissue biopsy. We did engine analysis. We found a TET2 mutation, and we found a MAP2K mutation as well. But the TET2 was the predominant mutation with a higher allelic frequency, 21% allelic frequency. And when you looked at the literature, so this AITL, they have a very high number of mutations of TET2, DNMT3. As you can see, this 50 to 80% TET2 mutation, 20 to 40% DNMT3. So it's very high. So any other neoplasm you have seen TET2 and DNMT3 to come? Can you tell me? Like, where do you usually see TET2 and DNMT3 mutations? Do you see them in lymphoma?
DLBCL was TAT2.
DLBCL, you are saying? Okay, some DLBCL can have TET2, not predominant finding though. But what other malignancy in the body usually show these mutations, TET2 and DNMT3? Where have you read them? Dr. Rubini, maybe you can comment.
MDS.
Very good. MDS, AML, isn't it? So myeloid neoplasm, we have seen TET2 and DNMT3 to come in myeloid neoplasms. And I think can they also occur without any neoplasm? Do you know any situation where there is no neoplasm, patient is absolutely normal, but they have a TET2 mutation? Like what that situation is called, Dr. Ruvini? So there is this situation called CHIP, right, or clonal hematopoiesis of indeterminate potential, where the body has a clonal hematopoiesis. So if you see that this is actually a very hot topic of research in today's world, but the fact is that as we age along, so let's say after 40 or after 50, some of these clonal hematopoiesis mutations comes in. Now the evolutionary reason why they do come is that as you age, what happens is our body's hematopoietic stem cell pool loses its diversity. So we cannot really keep pace with the need of producing more and more blood cells. So therefore, there will be some of this mutation that comes in, like TET2 and DNMT3, which gives it a proliferative advantage. So now those cells can produce more hematopoietic cells. So this is situation is known as CHIP, or clonal hematopoiesis with undetermined potential. They have this mutation, but they do not have any cytopenia, do not have any morphologic dyspoiesis. So they do not have any disease. This is just that this mutation is present. So, but the problem is that these mutations can then finally give rise to a clonal progression and to an AML, or sometimes atherosclerosis can also happen. So in a mechanistic model, what happens is that clonal hematopoiesis first comes, and then it might progress to a clonal cytopenia, and then finally progress to an MDS or AML-like situations. But so now, what about in this case? Like how come like a lymphoma, like a AITL expressed TET2 and NM3, right? So actually, if you see that there was this very interesting data that came from MD Anderson, where they showed that these patients, they actually did 22 patients of AITL and showed that the patient that has this myeloid-like mutation, they have the same mutation in bone marrow as well. So they have this clonal hematopoiesis as well of this similar type of mutations. And some of them actually progress to an AML. And what was interesting is that these occur from a similar clone, right? So this is a normal hematopoietic stem cell clone that has these 3 mutations, let's say. And then what happens is some of them go to lymph node and acquire some additional mutations, which is seen in blue, and become an AITL. Some of them remain in the bone marrow and finally may acquire some additional mutation like RUNX1, seen in green, and become AML. So it's the hypothesis here is that a chip clone can progress to either AITL or AML depending on the external stressor, external environment, and where it is happening, like either in lymph node or in bone marrow. This is again a similar picture, like you see in the normal hematopoietic stem cell, they might have all these 4 mutations. This is a case basically. So this is a chip-like mutation. And in AML, they acquire a second mutation like NPM1 becomes AML, whereas in lymph node, they acquire this ROA mutation and becomes AITL. Now that sounds very fascinating from a biologic perspective, right? Wow, that this chip can give rise to AITL. But what is the practical utility of it? The practical utility is that just like TET2 mutation patients can be treated with azacitidine or a hypomethylating agent in AML, there is some data now to suggest that a 5' azacitidine can help to induce some response in patients with AITL. So only because you could identify some myeloid mutations, myeloid-like mutation in AITL, you could then go and give these patients a 5' azacitidine and induce some response in this patient. That is why it is very important to identify these molecular findings or even flow cytometric findings to not only diagnose but also sometimes use it for therapy. So finally, I think we can end this discussion with the some common theme that has emerged from this very random discussion that we had today. One is that flow and NGS, why do we really need to do it? So first is that it provides a biologic framework, right, for disease classification or characterization. Like Shweta showed you NPM1 mutation that defines that AML. So that is the driving mutation and the driving clinical behavior mutation in that case. So that is why it is important to identify. Similarly, they can add very useful dimension that helps in accurate diagnosis. So, for example, we saw that case of FGFR1 where the flow pickup of T blasts were really helpful. That could point out that yes, this could be a T lymphoblastic lymphoma. And lastly, they identify therapeutic opportunities. So, for example, if it was PTGFRA, you could give imatinib. In this case, there was TET2 mutation, so probably the patient can be given a azacitidine. So that is why it's very important to identify this flow and molecular markers at today's world. So with this, I would end this discussion and we'll take some questions now. Shweta, you want to add anything to this?
No, I think.
Do you have any questions?
I think excellent talk, Shweta and Gaurav. I really enjoyed. I'm sure the student would have been overwhelmed with the heavy dose of molecular genomics, but at least the idea is that they all get stimulated that these things are happening and these are happening within your own country. So you can read about it, and they're all doable now. Whatever you read in the WHO books, it's all doable here, and they all have implications. Diagnostic to therapeutic. Any questions you have, students, or moderators? You have any comments, or students have any questions?
Actually, all cases, like most of the cases, what we will see is we will see till the workup of IHC and flow. That's all. After that, the molecular workup exposure is very low in most of the clinics or hospitals. So that exposure we got in these cases, how it has been worked up further, and the diagnosis itself is changes once the molecular comes into that. So that way it was very useful for us.
Yeah. So you can also understand the context, like in what situation, what molecular or what flow things should be, you can direct the patient to that. So that is, I think, is useful.
Yes.
And we usually don't do flow cytometry for staging marrows. We just do the bone marrow aspirate and biopsy. If required, we do some markers, but we usually don't do flow for staging marrows. But in your college, I think all the cases you do. So we can pick up some amount of infiltration also within the bone marrow.
Absolutely.
So
Yes. And we see cases where it really helps, like even in small level, you can characterize them.
Yes,
And
sir.
then we can talk to the histopathologist, like what he is saying. Like many times we call sir and say that, this is what we are getting, and sir will again get back, like this is what we are getting. So we can go to a final diagnosis. So yes, it definitely helps in that regard.
Like the Kunal showed you a case of AITL with a follicular pattern.
Yes, sir.
He showed you the vessels is in the follicles. Now, whether to call it a follicular hyperplasia or AITL follicular, it's a newer things we are evolving, and this combination of all these technologies, molecular flow, they help you to revisit your lymph nodes also. So,
yes, sir.
So, and if you have finances and if you have facilities to do it, all these sensitive techniques, they really help you understand biology much more, and you become much wiser. Obviously, morphology and clinical, nobody can take. They are still the gold standard.
Yes.
But these technologies really help you learn a step further. So we are lucky that, as Gaurav and Shweta said, in TMH we can do these technologies. But students can always apply for a fellowship or a residency program in institutes like Vellore, TMH, or AIMS, or PGI Chandigarh. These all institutes have, I think, everything under the sun, and they can learn good quality paths there.
Yes. I think one of the conclusions is that you should think about it. Like when a case comes, sometimes we're in very much hurry, right? So just to finish the case, or like you said, Dr. Subhasin, like if you do not have molecular or something, you may be tempted to just end the case on histopathology. And sometimes you do not look at the nuances of clinicals. There might be, for example, in the ITL case, the globulin was high, so that is one feature that is suspicious. Like you can think, okay, ITL usually have globulin high, so just take some time with each case, I think, is a message. Like you can think about that case, and then you can maybe think like what can be the abnormality, at least, like what can be the abnormal feature in this case, unusual feature in this case.
Even the second case, sir, if because in in that whatever you told, first you have taught it as a T lymphoblastic lymphoma, and in the bone marrow it was a different kind of picture. If you would have not correlated the case, it would have just got ended as T lymphoma.
Absolutely. So basically, keep on observing. Like we can only observe, right? So keep on observing and don't close yourself to a particular diagnosis. Think about all the features.
Very true, Gaurav. you don't ignore any feature, clinical or the lab.
Yes.
Even the monocytes are high. Don't ignore.
Yes.
You know, sometimes you say, okay, 12% monocytes, ignore it. You know,
Yes.
platelet count more than 4.5 lakhs, ignore it. You know, in India, 5 lakhs is normal. But that's why we do not pick up many diseases. We label them reactive. They may be reactive, but you have to first think of the other uncommon causes also. That's how you pick up the rarer lesions and diseases.
Yeah.
Any questions or comments? Shweta, you want to say anything?
Yeah. So, and in flow also, like while observing, you have to look at the normal parts also, like why are we calling anything abnormal? And why are the other everything else, is it normal? Like just finding one abnormality, we should not be happy that okay, this is the abnormality. We should look at every component and try to see if everything else is normal or not. That is also important while
Yes,
looking
ma'am,
at it.
that is true.
Absolutely. Yeah.
So students, you don't have to worry. You don't have to read the whole WHO book. You just
Yeah.
idea was to just stimulate you that these things
Yes.
are, you know, you need to think little. That's all. Just go in and forget everything what you have learned today. You just enjoy yourself. Don't
I
get.
hope you all enjoyed the students. They answered very well, I think. So I hope you all of you enjoyed and just, you know.
No, they answered very well. Means most of them, you
Yes.
know, they tried their best, and congratulations to you all. Thank you very
Yes.
much. So you want to
Thank
show
you
the
so much.
next
It was
talk
great.
slide, Subhashini? You can just share
Yeah.
the next two slides.
Meanwhile, when you're
Next
sharing,
week.
Yes, and sir.
Yeah. We have two more talks coming up next week. We have a seminar on accessory cell lesions on Thursday by Dr. Borges. Yeah. On Tuesday, we have digital pathology and artificial intelligence. So this is a short note questions for all postgraduates in pathology. But forget the short note question. You will learn from the horse's mouth. Swapnil is one of the best pathologists who knows about AI. You know, if you want any pathologist to understand